Hey everybody, I just want to record this lecture quickly on pulmonary edema. Hopefully do this in the next 25 minutes or so. Really just want to discuss the pathophysiology of pulmonary edema, discuss causes and some common radiographic appearances, provide some useful tips so you don't just call everything that's white on a chest x-ray edema. Big categories, you think about two types of pulmonary edema. You're either going to have cardiogenic or hydrostatic pulmonary edema. They're going to have very distinct stages that we'll go through, or non-cardiogenic edema. We'll also talk about some special cases and mimics. For hydrostatic or cardiac pulmonary edema, just think about it as a balance between hydrostatic and oncotic pressures. You can, most commonly, you're going to have increased pulmonary venous pressure from left heart failure or volume overload versus low oncotic pressure from chronic liver or renal disease. This is a nice module that's in the Radiology Assistant website that runs through the three different phases. I'll borrow some of their graphics and run through those quickly. You're going to have varying degrees of pulmonary vein dilatation and redistribution. Then you're going to have, for the first stage, for the second stage, you're going to have leakage of fluid into the interstitium and pleural space. And then for the third stage, alveolar filling. And each of these stages have radiographic findings, and each of these stages has pulmonary capillary wedge pressure that increases accordingly. So for stage one, you're going to see cephalization, central venous congestion, pulmonary venous hypertension, cardiomegaly, and wide vascular pedicle. This is a good example of those things. Again, central venous congestion is another kind of a general term that's implying that there's too many vessels radiating from the hilum and in an abnormal distribution, but you don't see the fluffy clouds of alveolar edema, and you don't see the the curly lines from interstitial edema. So kind of just in that phase one. Another example there. Just remember that on a supine film, it's normal to have redistribution. So don't call redistribution on a supine film, because that is what you'd expect. For cardiomegaly, you're measuring the transverse dimension of the heart. On a PA, it shouldn't be greater than 50%. You can either measure the whole thing and the whole chest and do math. I try to just find the middle of the spine and go over once so I don't have to do math. It's another way to do it. Be mindful of pericardial fat pad. Don't measure that. So we talk about a wide and vascular pedicle. Some textbooks will say 6 centimeters is your cutoff point, but then greater than 8.5 is going to be abnormal. I remember in the trauma setting when we used to have pagers, people used to use their pagers as when we had print film, which is funny. You can also identify the azygous vein. It can be distended. But as you notice, the example here, this is basically what all of our supine film look like. So you want to be mindful of the effects of a supine patient on that wide and vascular pedicle. Again, here's an example, just redistribution in a supine patient. When they stand up, it looks totally normal. So we have a tendency in the ICU setting to overcall edema. Because of an overcall, central venous congestion, these types of things, because of this phenomenon. So don't do that. I try to hold myself to the standard of identifying curly lines before calling interstitial edema. And I tend to, in the ICU setting, when I know they're kind of semi-erect or supine, I tend to go a little bit easy on the vascular redistribution. It's just something to keep in mind because it can be normal. This patient has a large azygous. You can see that on the concurrent CT. So that's, again, stage one is going to just be your central venous congestion, cephalization. Stage two is going to be interstitial edema associated with a slightly higher capillary wedge pressure. And really the hallmark of interstitial edema are going to be curly lines. It's a good example of curly lines. So they're going to be these horizontal lines radiating out. That's fluid in the fissure, but horizontal lines radiating out to the pleura. Sir Peter Curley is an Irish radiologist. He was knighted for his services to the radiology world, something to aspire to. Curly A's extend from the hyla. Curly B's are peripheral interlobular septa, and then curly C's or reticular opacities felt to be curly B's en face. So then it begs the question, can Americans be knighted? The answer is yes, but it's complicated. There's 5 ranks of knighthood. Only the top 2 are called Sir or Dame. And these are the Americans you can see that have been knighted. Bill Gates, George Bush, Bob Hope, Colin Powell, James Watson, Spielberg, Rudy Giuliani, and Ronald Reagan. What happened to Rudy Giuliani, America's mayor? This is the Four Seasons. His team booked this event at Four Seasons thinking it was the nice Philadelphia hotel. It turned out to be a landscaping company who had a lot of fun selling t-shirts after that with that logo. Unbelievable. Again, some more curly B's, NC's, and A's. Good. It's another example of curly lines. So on to alveolar edema, stage 3. Again, corresponding capillary wedge pressure, kind of the cotton wool or fluffy clouds appearance. It's actually filling of the alveolar spaces with fluid. It's going to be dependent and posterior in most ICU patients. It's kind of a butterfly or bat wing appearance. This patient after PEA arrest, bilateral airspace disease. Sorry. Pleural effusions are going to be bilateral in about 70% of patients with CHF. It's a test question that comes up sometimes. They want you to realize that the lateral is going to be more sensitive to small pleural effusion. So you can see greater than 175 cc's on the PA. On the lateral, you can see as little as 75 cc's. On an AP that is semi-erect, you can hide a liter. I mean, it's amazing. If you ever look at a CT on an ICU patient that has effusions and look at the same day x-ray, it make you feel bad about yourself. Keep that in mind because they often just kind of run up their back and layer posteriorly. So and you can kind of identify that as a layering gradient, but just when you're reading ICU films, use what you have. Use the abdominal CT that was done a day or two ago. Use the chest CT or the head and neck CT. Don't make it harder than it has to be. Subpulmonic effusion can also manifest as lateral displacement of the diaphragm apex. So the diaphragmatic apex should be in the middle of that lung. It just pushes it over. Something that people want you to identify in a testing situation for sure. So here's an AP layering pleural effusion where you don't really see that nice meniscus, but you just see this graded opacity. So the effusion's kind of running up their back. And then when they get a subsequent AP and lateral, you can get a sense of how big it is. I would call these moderate. And for me, moderate is, say around this, filling up to around here or here, implying that if they're symptomatic, they should probably do something, thoracentesis or chest tube. Small, really not going to be able to intervene and shouldn't need to. Large, you should probably intervene regardless if they're symptomatic or not. Kind of how I judge small, moderate, or large. Sometimes when you see this image and you are not sure whether this is elevation of the right hemidiaphragm or effusion, elevation of the right hemidiaphragm is not going to change where the apex of the diaphragm is, which should be here. You see it's displaced laterally, so that's going to imply that is an effusion. This is edema on CT. It layers dependently in the secondary pulmonary lobule. So just something to keep an eye out for. Sometimes when we're reading CTs, when we see edema, it's a little distracting because we're just so used to seeing it on X-ray, but not on CT. But just keep that in mind, especially in our hospitalized patients who seem to get more and more CTs these days. So patient, shortness of breath, no fever, and a normal white blood cell count. Looks like bilateral airspace disease. And angiogram, intralobular septal thickening, ground glass. She was pregnant. Thought this was a postpartum preeclampsia. It's rare. Thought it was a postpartum cardiomyopathy, but her echo was normal. Not really well understood. Just showing you as an additional case. BNP is something that can be helpful if you're something about the case and you want to trust your instincts. When you look at something, you say, "Oh, that's funny looking edema." Trust your instincts. Dive into the chart. Do a search for BNP. It's easy enough to do. It can help when you want to just double check something or something looks funny. Would be great if we could dive into the chart for every case. We can't, but certainly ones that strike you as something, looks like edema, but the heart's a normal size, or it's a young person. Certainly take the time then to investigate a little bit. Good, so that was just a quick run through of cardiogenic or hydrostatic edema. Hopefully that's pretty straightforward. We'll run through some non-cardiogenic edema and then show some cases. The really non-cardiogenic edema is capillary endothelial injury, where you have fluid and protein loss into the interstitium. When you have that appearance, it's a hard, because it looks like edema, looks like cardiogenic edema. So it helps when you have by definition, has to have a normal capillary wedge pressure. Acute lung injury and acute respiratory distress syndrome, so ALI or ARDS, really just differentiated by the degree of hypoxia. Things that we're very much more familiar with this past year with COVID. You can have it as a lung infection, as we have with viral pneumonia and COVID, or you can have it can be from an infection someplace else. You can have pancreatitis or a skin infection, and you can get an ARDS in your lungs. Trauma, inhalational injury, fat emboli, some drugs, head injury. Effectively, you'll have patchy airspace disease, some coarse reticular opacities, felt to be somewhat more peripheral than in hydrostatic edema, but that's in real world, that's a tough distinction. Pleural effusions are going to be less common than in hydrostatic edema. It's going to be slow to clear and then can kind of coarsen over a number of days and turn into a fibrosis. So this is one that should strike you as, hey, that's funny looking edema, normal heart, very severe airspace disease. This is someone with ARDS. And then over the course of times, you can see how it starts out kind of fluffy and then coarsens over time and turns into a more fibrotic type pattern. Drugs, recreational and prescription drugs can do it. Transfusion reactions can do it. Be mindful of transfusion reactions. If someone has a transfusion reaction that causes a cascade, if we confirm that the imaging, which looks like edema, could be a transfusion reaction, it creates a cascade of events where they have to pull any blood products that came from that donor, which sometimes get split into many different products. So it's causes a little bit of a headache when we do confirm that suspicion. So be mindful of that. So a patient who had shortness of breath at the dentist, looks like some mix of alveolar and interstitial edema, intubated patient. There's a case report of nitrous oxide leading to pulmonary edema. I thought was interesting. Patient recovered. You can have a mixed permeability and hydrostatic edema, so a little bit of both. See that with neurogenic pulmonary edema, re-expansion pulmonary edema after thoracentesis, and high altitude pulmonary edema. Head trauma can give you what looks like edema. This is something that re-expansion edema is something that I'm not sure how common it is. I probably feel like I've only seen one or two good cases after doing hundreds of thoras. It's not sure if it's a combination of the negative pressure that you create by pulling fluid out quickly, the volume of fluid that you pull out. That's why we typically stop at 1.5 liters, or to prolonged collapse of the lung and then a reperfusion type effect. It's a patient we did a thora on. Had a lot of shortness of breath afterwards, and you can see kind of a local pulmonary edema in that area after thora. Supportive care. Negative pressure edema from this is a laryngeal edema causing negative pressure in the chest when that can pull fluid into the alveoli. High altitude pulmonary edema is due to a rapid descent above 10,000 feet. That's why I've never done this, but I think I've seen those shows where they like hike to base camp and let your body acclimatize or something. Basically a combination of pulmonary hypertension and permeability edema. It's really not well understood when I looked it up for this, but you basically get a pulmonary edema pattern. Really, you just shouldn't be up there. This is one of our residents, Kareem Ravar, who was a climber. He had this picture, which was pretty awesome. Now on to some cases. So this is a patient with the right upper lobe airspace disease, bad heart. You look in the chart, no white count. Looks like you would kind of want to call it edema, but it's weird that it's only in the right upper lobe. So what you can have is a focal edema from mitral regurgitation. So if you rupture a papillary muscle or have really bad mitral regurg, basically the regurgitant jet just shoots right up the superior pulmonary vein and causes a focal edema in that spot. It's a pretty well-known phenomenon, kind of a fun call when you find it. You can always look in Epic. Echoes are listed under procedures, I think, in Epic. Kind of a hard place to find them. This is what I called mitral regurg edema, isolated in the right upper lobe on CT. These are mitra clips, which is basically this endovascular procedure for mitral regurg where they put this little clip in the mitral valve and decreases the regurgitation. Seeing quite a few of those recently. If you have a huge PE on one side, you can get unilateral edema on the other side, or a postoperative nephrectomy where they're in the decubitus position for a long period of time can give you a unilateral pulmonary edema. Rare, but just other cases of asymmetric edema. You don't necessarily want to lead with asymmetric edema because it would be an uncommon thing, but certainly something to keep in mind if everything fits. It's a patient who all clinical signs were pointing towards edema, but it was hard to look at it and just be like, yeah, this is normal edema. It's kind of patchy. This was his baseline. We noticed he had very severe emphysema, and it's a phenomenon where if people have severe upper lobe emphysema, you can't have edema where you don't have alveoli. So you have this kind of patchy filling in of the alveoli that are left, and you can kind of get a more patchy appearance of edema than we're normally like to think about that. Kind of thought about that as like a sponge. We wrote a fun little article about that, about asymmetric edema. This is someone who has severe apical emphysema, and then their edema pattern couldn't get up there. So it's just kind of a fun thing to think about. A couple mimics. So again, when the radiographic appearance doesn't really fit the clinical scenario or established patterns, consider some alternatives: viral pneumonias, PCP, aspiration, alveolar hemorrhage, interstitial lung disease, lymphangitic spread. These are all diagnoses that there is going to be a lot of overlap. This just looks like severe airspace disease. I would have to dive into the chart to know what was going on with this patient. And there's actually a code for disturbed Starling forces. I think I remember seeing that as an indication once. And then but a lot of the times we don't know. Again, here we have bilateral airspace disease, fairly symmetric. And you look in Epic and it says white count of 0.4. So when you see someone who has bilateral airspace disease, I think for all comers, you'd call this edema, but you want to be very careful in neutropenic patients because if they get a bacterial or viral infection, they're not just going to localize that to a lobar pneumonia as you and I would. They can manifest as a more diffuse process. This ended up being we felt it was a viral pneumonia. It's kind of slightly more patchy, a little bit left greater than right. Airspace disease, went on to CT, no white count, normal BMP, afebrile. So the patient goes to CT. This is the kind of the crazy paving appearance, interlobular septal thickening and ground glass. And that is usually, when you describe that, crazy paving appearance will usually lead you to a diagnosis of pulmonary alveolar proteinosis, or PAP. Sometimes they'll ask, what is a treatment for PAP? And that is choice C, whole lung lavage, which sounds terrible. This patient with multifocal pneumonia, but looks like edema. So it looks like some more basilar reticulation. So we move on to CT. We see fairly normal looking lungs and then basilar honeycombing. This is going to be a UIP pattern, but again, you just showing these again as bilateral lung disease. Not all bilateral lung disease is edema. Patient with a history of breast cancer. On the X-ray, you can see this interlobular septal thickening. It looks more right than left, which is unusual. You move to CT, and they have interlobular septal thickening. If I point to you right here, it's kind of nodular interlobular septal thickening instead of smooth interlobular septal thickening. That can be a bit of a tough distinction sometimes, but leading you towards diagnosis of lymphangitic carcinomatosis from the breast cancer. It's a young person with kind of these asymmetric airspace disease, and we find out that they have HIV, fever, cough, and a white count of 3. We go to CT, and just kind of ground glass opacities. This is PCP. Can be a mimic of pneumonia, so just be mindful of the patient setting and CD4 count. CD4 count is going to be below 200. You want to consider that in your differential. That's when prophylactic Bactrim is started. So a good number to remember CD4 count below 200 to include PCP. ICU patient, bad airspace disease, very dense. And when it's so dense like that, one consideration when you have for things is alveolar hemorrhage. That's what this patient had. But it'd be very hard to prospectively look at that and just say, oh, that's a great case, alveolar hemorrhage. Getting to diagnoses like these can often take a little bit of chart digging, or we just call it one thing and the team comes down and, we call it pneumonia and the team comes down and says they don't have pneumonia, and you can work through it with them. But again, just trust your instincts when things don't feel like they're fitting into the right bucket. Young man with shortness of breath. He has lung mets and this diffuse severe ground glass opacities, testicular cancer. You want to be thinking about drug toxicity. If you hear testicular cancer, shortness of breath, diffuse ground glass opacities, bleomycin is probably one of the more common drugs that will cause this pattern. So in the chest, I would say amiodarone's a big offender. bleomycin. It's not common, but it's but certainly a bad actor. Again, this radiology assistant website has a nice heart failure module that I stole a lot of those pictures from. So use that as needed in addition to the other chest findings. There's also, plenty of articles on pulmonary edema. Not all of them are helpful. So here I like this one. Neurogenic edema manifests as bilateral homogeneous airspace consolidation that predominate in the apices 50% of the time. I just thought that was funny because if you say something's upper lobe 50% of the time, that's not a particularly helpful. But a lot of stuff out there. Oh, quick bonus question. Came across this in our CT storeroom. It was a safe for flammable material. And I was kind of curious, what does a flammable safe cost? And what's inside. I was very intrigued. So I think I looked, it was like a $400 safe. So then even more intrigued, I had one of the CT techs find the key and unlock it for me to show me what was inside. And it was Purell. So I guess it's the hospital safety thing that you can't store that stuff on the shelf. Thought that was amazing. Great, thanks. Quick run through of pulmonary edema. Hopefully that's helpful. See you in the chest reading room.